We're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, and that includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, the Métis Charter community of the Lower Mainland region, and wherever you are in the province or anywhere else on Turtle Island, to spend some time reflecting on what we each can do as individuals towards truth and reconciliation, both with the people and with the lands. And I think we're reminded quite often, and again this weekend, while the atmospheric river approaches, about how important it is that we do take care of the land and learn from its peoples how best to do that. Next slide. So Province-Wide Rounds is a collaboration between UBC Division of Nephrology and BC Renal. We're grateful to all of our industry partners, but to all of you in the various health authorities for the contributions that you make to education, learning, and improving patient outcomes through that education and learning. Next slide. So today's rounds, we're pleased and privileged to have Dr. Sam Wiseman, who's a professor of surgery at UBC and attending surgeon at St. Paul's Hospital. He's also the director of research for PHC Department of Surgery and chair of BC Cancer Surgery Thyroid Cancer Tumor Group. He hails from University of Manitoba originally, and also has an advanced training council head and neck surgery fellowship, and currently has over 200 peer-reviewed scientific publications, a number of different book chapters, and is an editor of textbooks of Gray's Surgical Anatomy and the new textbook, 50 Landmark Papers Every Thyroid and Parathyroid Surgeon Should Know. His research has been presented at meetings and centers, and he's off to the American Surgical Society this afternoon. So we're really pleased that we were able to catch him and have him present to us on current understandings, surgical perspective as secondary and tertiary hyperparathyroidism. So welcome, Dr. Wiseman, and thank you very much for joining us.
Great. Well, thank you very much, Dr. Levin. I'll share my screen. And we'll go into presentation mode. There we go. So hopefully everyone can see and hear me, right?
Yeah, perfect.
Good, good. Excellent. Well, it's a real pleasure to speak here today because being at St. Paul's for many years, I think I've met many of you, not all of you, and I've taken care of many of your patients. And this is a topic that you don't really hear discussed very often, and I think it's a topic that surgeons don't really even talk about in surgical meetings very often. So I thought it would be interesting to look at the literature and hear a little bit about what's and if you hear a little bit what's been going on lately. And so the goal of the talk is to look at the surgical management of both secondary and tertiary hyperparathyroidism, and you'll see I'll jump back and forth during the talk between the two. So hopefully both the transplant and non-transplant nephrologists in the audience will be interested. And as well, I'm going to also focus on, there's been recent guidelines in the last couple of years from the American Association of Endocrine Surgeons on the management of these patients. And you may not have been as aware of these. And so I sort of have incorporated these into the presentation into terms of their evidence-based recommendations. And so these are the guidelines that I mentioned. They came out just within the last couple of years, and they really provide a very helpful document, I think, especially for surgeons in terms of the management of these patients. They're also endorsed by the American Society of Nephrology, and I believe there's a lot of nephrology involvement in their creation as well. So I don't really have to explain to you all the pathogenesis of secondary hyperparathyroidism. I'm going to start talking about secondary first. And really, as you all are very well aware, it's really that interaction of PTH, calcitriol, and fibrographic growth factor 23, which allows for maintenance of our normal serum concentrations of calcium and phosphorus. And we have this interaction between the GI tract and the kidneys and the bone that maintains our homeostasis. And as there's progression through the stages of chronic kidney disease, you have a progressive rise in FGF, and then you have a progressive fall in the calcitriol and rise in PTH. And in this deranged state, you have this stimulation of the parathyroid cells, leading to really driving PTH in this environment of low calcium, high phosphate, low calcitriol, and high PTH. And so really, initially, it's a physiological adaptation. And it's an interesting little table comparing primary to secondary and tertiary, where we have in secondary and we have a lower calcium levels or normal calcium levels, and tertiary can have as high or normal, and PTH is up in both, and vitamin D levels are usually down in both. And it's this chronic stimulation, this chronic elevation of PTH that eventually becomes pathological. And as you can see, as you progress through renal failure by stage 5, 100% of people do have some component of secondary hyperparathyroidism. And so we see this at the level of the parathyroid itself and the cells, this environment of low calcium, high phosphorus, low vitamin D, with the chief anoxophil cells being stimulated with from normal glands through diffuse hyperplasia to early nodularity, and then it gets to the point where the glands become nodular. We actually see these nodular glands in the operating room, and these are mostly the chief cells where you have a monoclonal proliferation with downregulation of the vitamin D receptor, the downregulation of the calcium sensing receptor, and then you get these sort of single, very nodular, abnormal glands. And these are quite massive and impressive during surgery. They're less responsive to the circulating ionized calcium and calcitriol. And then you basically enter into sort of the point of no return where they become autonomous in the setting of a refractory or tertiary, and where you have these multiple hyperplastic glands. So what about the treatment of secondary hyperparathyroidism? So this is really I think it's a bit kind of a hot topic. It's not really in the context of the guidelines. They don't really give very specific guidance. It's mentioned that, and I think really it's the KDIGO guidelines from 2017, which were sort of carried over from earlier guidelines, are really what's used, where we talk about PTH levels that should be maintained in 2 to 9 times the upper limit of normal. It's frustrating, I find, in the literature that we have to convert the PTH units, but this comes to between around 30 to 60 picomoles per liter to maintain bone health. And with rising levels or levels above range, treatment is recommended. And it's here we can see this was a table from the guidelines where they looked at the incidence of PTH over 600 in different countries, and it found, actually interestingly, in this series, Canada had almost a third of patients were above that threshold. Regardless, you're all probably quite also aware of the DOP study, where they looked at this massive population of renal patients, and they found the hazard ratio was like 1.22 for mortality with patients of PTH greater than 600 or 9 times the upper limit of normal. And so this is kind of it seems to be the number that the literature hangs its hat on. There are other guidelines where the guidance is a little bit different. It's interestingly, in the patients that I see for surgery, the PTH is usually much higher than 63. In fact, I spoke to a guy yesterday. It was more than 120. Usually their numbers seem to be over 120 when they end up being referred for surgery. But that's kind of my gestalt impression. And as you all are well aware, and you all are managing your patients, I think probably most renal patients are on some type of first-line medical treatment for secondary hyperparathyroidism with some type of PTH lowering therapy, calcium mimetics, calcitriol, or vitamin D, or some combination. And it's interesting when I see these patients also in referral. I can see that they're on a variety of drugs. It's very challenging to understand what's been tried and what they've been through, and it's quite variable, it seems, from nephrologist to nephrologist in terms of the actual protocol that's followed in these people, and they all seem to respond a little bit differently to some of the medications. In terms of the indications for parathyroidectomy, beyond these sort of numerical suggestions, we talk about patients refractory to medical therapy who have uncontrollable PTH without precipitating hypercalcemia calcemia or hyperphosphatemia, and people who have kidney transplant anticipated within 6 months. It doesn't that indication, it doesn't seem to show up. It also seems to be a bit variable when we see these people in consultation. And we talk about cortical bone fractures, muscle weakness, uncontrolled pruritus and skin lesions, and also as being other uh, indications. And it's interesting, it has been studied, the criteria which trigger referral of dialysis patients for parathyroidectomy. And a number of contributing factors include patient age, race, their PTH levels, their disease severity, and transplant candidacy. Certainly, calciphylaxis is a very uncommon indication we've seen. It's pretty horrible. It's come up in a number of patients. So what are the benefits of parathyroidectomy for these patients? Literature suggests that by reducing their PTH, calcium, and phosphorus, you can help reduce their symptoms and reduce pruritus, muscle function, improve muscle function, left ventricular function, reduce anemia, and quality. There is some good quality of life literature, and also improve cognition, reduce coronary artery calcification, and lower the risk of fractures. And unfortunately, there's really no level one evidence. There's no randomized trials comparing surgical therapy to medical therapy for the treatment of secondary hyperparathyroidism patients. And so, so if we don't have that type of data, what can we base our management on? And this is actually quite a recent meta-analysis, just came out earlier this year from Herb Chen's group from Alabama, which really aim to look at the benefits of parathyroidectomy versus medical treatment in reducing mortality and managing key lab parameters in dialysis patients. And they included over 24,000 patients, and they found that there was a not surprisingly significant reduction for parathyroidectomy versus medical treatment, all-cause mortality. You can see the numbers there, and as well as cardiovascular mortality. And it was really seemed to be most beneficial in patients with PTH greater than 585 or 62, which not surprising with this number of 600 that we've quoted already. And there was really no mortality difference when cinacalcet was added alongside standardized medical treatment. But with the surgery compared to medical treatment, there was a larger decrease in PTH, calcium, and phosphate relative to the medical treatment. So now I'm gonna bounce back and forth between secondary and tertiary hyperparathyroidism. So we're gonna talk a little bit about tertiary hyperparathyroidism. And so tertiary hyperparathyroidism, I find it a little bit of a interesting entity because not all patients are kidney transplant patients, but when we talk about tertiary, we tend to think about kidney transplant patients encompassing most of this population. And so these are a couple of quotes which I thought really were interesting, and I think helped with conceptualization of this, because there is a lack of consensus regarding an exact definition for tertiary. And it again, it's this advanced stage autonomous secretion of PTH, but does not necessarily define hyperparathyroidism as occurring only after kidney transplant. And this is like this next quote, I think, is perhaps the most interesting, where they talk about kidney transplant being a screening procedure to eliminate all the hyperplastic parathyroid tissue that might return with reestablished calcium phosphate homeostasis, leaving only autonomous tissue that does not respond to feedback. It's a very parathyroid-centric description in terms of the purpose of kidney transplant, but nonetheless, I think it really captures it nicely that not all tertiary patients have kidney transplant, but it can be difficult to define the tertiary patients who are pre-transplant. And so in terms of tertiary hyperparathyroidism, we talk about persistently elevated calcium at 6 months post-transplant. And this can occur in up to 10% of patients at a year post-transplant. And it's interesting, if you look at the PTH levels, they don't necessarily correspond exactly. And you can have ongoing elevation of PTH in a significant proportion of even normal calcemic patients. And we talk about tertiary hyperparathyroidism increasing the risk of transplant related dysfunction and failure. And this is a recommendation from the guidelines, which is referral for surgery should be placed within 12 months post kidney transplant in the setting of tertiary hyperparathyroidism. And I think this is something that we have actually instituted recently at Providence. In terms of the effects of tertiary hyperparathyroidism, I'm sure you're mostly familiar with these: osteopenia, osteoporosis, fractures, vascular calcification, anemia, effects on glucose and lipid metabolism, cardiovascular disease, and as already mentioned, allograft dysfunction. Again, you're all doing this routinely on your patient population. The first line treatment is medical with nutritional vitamin D, receptor activators, calcimimetics, and antiresorptive agents. And they all have their pros and cons, as you can see here. And interestingly, there is a single randomized trial on medical versus surgical treatment of tertiary hyperparathyroidism from Spain. It's a small population. I'm sure that most of you are aware of it, but 30 patients randomized to subtotal parathyroidectomy or cinacalcet, and at a year, about two-thirds of the cinacalcet group and 100% of the subtotal group achieved normal calcemia, significant difference. The subtotal group had a greater reduction in PTH and improvement in their femoral neck bone mineral density, though vascular calcifications were unchanged. And after 14 months of treatment, surgery was more cost effective. And so they concluded subtotal parathyroidectomy was considered superior. Now, this is just a single small randomized trial from Spain. But what else does the literature say? And again, a fairly recent systematic review looking at 47 papers where they found that the cure rate, regardless of whether it was a subtotal or total parathyroidectomy, was very high with a low recurrence rate, as you can see there. But after cinacalcet, it was really only about just over 80% achieved normal calcemia, and really intolerance of the drug, which, as most of you also know, is GI intolerance. The drug had to be stopped. And in a subgroup of these studies, they also looked at renal graft survival after surgery versus cinacalcet therapy, and they found that actually it was comparable. Basically, they concluded that from this study that the surgical therapy had higher cure rates than medical therapy for tertiary disease. And so really, this is the recommendation, is that really parathyroidectomy is the treatment of choice for patients with hypercalcemic tertiary hyperparathyroidism, and also in patients with, but should be also considered in the post-transplant setting in these patients, and those on long-term dialysis. So what about the pre-op workup and management of secondary and tertiary hyperparathyroid patients? So when we're operating on when these patients have been referred and we're going to operate on them, we do preoperative imaging, but we know that the approach involves exploration of all four of the parathyroid glands because they're all going to be abnormal. So why bother even doing any imaging for these patients? And so really there's two scans which are standard: the sestamibi scan and the nuclear medicine scan. And really the reason we do this is to look for ectopic glands that we wouldn't normally, in places where we wouldn't normally be looking at surgery. So that's really the rationale for that. And for ultrasound, it also allows us to look at for concurrent thyroid pathology. You really want to manage a concurrent thyroid pathology at this time of parathyroidectomy, and because reoperation in the central neck with scar tissue is associated with a significant amount of morbidity, specifically relating to recurrent nerve and injury risk. And so, but there is actually very limited literature which show nodularity in the secondary and tertiary parathyroidism patient populations is not uncommon, and thyroid cancer incidence may be a little bit higher than in the general population. So these are really standard in the pre-op workup. If we are evaluating and biopsying a thyroid nodule, I would fairly routinely not only send a specimen for cytology, but I'd also ask them to do a pass for PTH measurement, because one of the ectopic locations of a parathyroid can be intrathyroidal, and routinely we wouldn't remove the thyroid at the time of a parathyroid procedure necessarily, and so it can provide us with a little bit more information if they're undergoing a biopsy anyway. In terms of preoperative management, according to current guidelines, they talk about at least 48 hours of initiating preoperative calcitriol for these patients. Not something that we've really routinely done here, I'm aware of. Preoperative vitamin D repletion is also important. These patients can at times have fairly low vitamin D levels, and then the use of calcimimetics should not be stopped preoperatively. They can be continued for those patients prior to parathyroid surgery. In terms of preoperative management, they also give some other recommendations. There should be a preoperative renal function evaluation within a month of the procedure. As well, cardiac optimization is important. As you're all very aware, can be significant cardiac comorbidities in this population. They talk about routine preoperative ECG and echocardiograms, and hypertension management is also important as well. And they even give some parameters here of uh, pressure less than 180 over 110 preoperatively, and to continue their existing antihypertensive regimen pre-op. We often will see that sometimes patients will stop things when they are kept NPO, and this can cause a lot of hypertension for anesthesia to deal with. In terms of the dialysis patients, they taught, not surprisingly, it's good to make sure that their electrolytes are assessed close to surgery and normal, that the day before surgery, dialysis is recommended. They don't talk about heparin-free dialysis anywhere in these guidelines. Interesting, but that's something that we've done for a long time. As well, optimization of the hemoglobin in these patients preoperatively is mentioned, and as well as platelet function. And they even mention that for bleeding, desmopressin can be administered intraoperatively if there's a concern. These patients do tend to be a bit more oozy than the average patient, and but really generally there usually would not be significant blood loss from this operation. It would be quite unusual. In terms of intraoperative management, preoperative antibiotics for this clean procedure is not required. They talk about steroids used for nausea and vomiting, as well as in the circumstances of suppressed hypothalamic pituitary axis for stress steroids. And in general, we don't use chemical prophylaxis in this population. It's generally not required. We use sequential compression devices. They're up and moving around usually very shortly after the operation. Yeah, a little bit about the operative approach. I don't know if you've really heard much about the operative approach in terms of the different types of surgical options for these patients. So, in terms of secondary hyperparathyroidism, our goal is to decrease the source of excessive PTH, and whenever we're doing these procedures, we're counterbalancing the risk of recurrent or persistent disease versus the risk of postoperative hypoparathyroidism. And so there's really no single uniformly recommended procedure. Some surgeons do a single operation for all patients. Other surgeons select operations based on age, comorbidities, and likelihood of renal transplantation. And that's a difficult thing to know when we refer these patients. I mean, I'll ask the patients, "Are you a candidate for? Do you know if you're a candidate for transplantation? Are you on the list?" But there's sometimes a lot of vagaries around that uh, when I'm talking to them. But because it's important to know, because in patients who are likely to undergo renal transplantation, they're more suited for procedures where the operations preserve some type of parathyroid remnant or parathyroid tissue. So what about secondary hyperparathyroidism? What are the operative approach for these patients? So subtotal parathyroidectomy is the approach that we've traditionally adopted here, and I think it's generally the favorite approach in most centers. This is the removal of 3.5 parathyroid glands with preserving a portion of a gland on its blood supply. And the idea is to reduce the duration and severity of post-op hypocalcemia. It often will include performance of a transcervical thymectomy. We'll talk more about thymectomy. Not all patients really have much of a thymus. And when we're doing these procedures, the things we're thinking about is we like to preserve the most normal appearing gland, not the giant nodular, very abnormal gland, the smallest gland, and most importantly, the most viable appearing gland. And we prefer an inferior parathyroid gland because if these patients develop recurrence over time, the lower glands are anatomically located anterior to the plane of their recurrent nerve. And so with reoperation, the morbidity is less with respect to the risk of nerve injury. In terms of the remnant, it's interesting. There are a number of numbers that are quoted in terms of milligrams of tissue. We don't actually remove it, so we don't really, there's no way of weighing it. I suspect that somebody had sort of weighed tissue at some point, and when they thought there was something that looked like the right size remnant, they talk about half to two-thirds the size of a normal gland. And there's a procedure they describe as where somebody used the term near total parathyroidectomy, where they leave like a 3 millimeter remnant. But this is all really based on surgeon experience. And the reason that I have a picture of Gollum here from Lord of the Rings is that it's uh, uh, it's really based on the surgeon's eyeballs and decisions like what is really an appropriate remnant for that patient. And it's kind of a bit of a Goldilocks phenomenon, not too much, not too little, just right. And so it's very sort of not the most scientific maneuver. Total parathyroidectomy without autotransplantation for secondary hyperparathyroidism, where all glands are removed. This is standard in some centers. I've not seen this performed in BC commonly. And when we do this, we really rely on supernumerary glands and parathyroid rests that reside in the thymus. And so when you do this procedure, you should definitely not do a transcervical thymectomy because it's interesting, after taking out all four parathyroids in this population, there is a measurable PTH months to years later. And not surprisingly, the rates of transient hypocalcemia and permanent hypocalcemia can be quite high. And certainly this is something that the patients need to be made aware of preoperatively. And as well, after these procedures, not surprisingly, patients will often spend, as you're all aware, several days hospitalized with close monitoring. What about total parathyroidectomy with autotransplantation? This is done, I think, more selectively, where all four glands are removed, and then there's some tissue removed outside of the neck. Often it includes a transcervical thymectomy as part of the procedure. And the rationale is a concern regarding the viability of the remnant, if three glands are identified at surgery, and if circumstances where intraoperative PTH is utilized. And we'll talk about that shortly. And what should be transplanted? Again, the most normal appearing tissue, a number of fragments are placed into muscular components. Usually that's our preference. They're really well vascularized. There is data that shows you can implant this tissue subcutaneously. And often it's usually placed into the brachioradialis, into the non-dominant, non-shunt bearing arm. It can be challenging if patients have gone through more than one shunt. And the sternocleidomastoid has been used, or there's some other places. There is a technique which involves suspending the parathyroid tissue, morcellating it and suspending it in saline and injecting it into the muscle. I find that in circumstances of recurrence, it could be much more difficult to manage than placing discrete pieces in pockets. And that's an approach that I haven't personally gone for. And so this idea of autotransplantation, where you do have a period of delayed function for engraftment time, you can have late graft failure as it heals. There can be scar tissue that causes ischemia of the grafts, and so they can fail actually late, which is interesting. As well, they can become overactive over time, and even they can become, people can develop tertiary hyperparathyroidism. It's been reported in grafts after renal transplantation. Transcervical thymectomy, why is this? And it's because of really this high prevalence of parathyroid tissue in the thymus, in terms of in the setting of secondary disease, there is a high incidence of supernumerary glands, so more than four glands, five glands, six glands, even more. Ectopic glands, meaning glands that are outside of the neck, places most commonly the thymus, probably about half the time. And these parathyroid cell rests, which nobody would ever really be aware of in somebody who isn't in renal failure, but can become really driven by that process of hyperplasia and stimulation in the renal patient. And so the approach can be a bilateral transcervical thymectomy, where we pull the thymus from under the clavicle on both sides, or unilateral, perhaps if you're concerned that there is a ipsilateral gland that's not identified. Not all patients really have a significant thymus to remove. It involutes in quite a few people, and so it depends on what we find, whether this is necessary or not. And again, in terms of total parathyroidectomy without autotransplant, as already mentioned, this is generally not performed. So looking at comparing the surgical approaches, looking at in secondary hyperparathyroidism, looking at subtotal parathyroidectomy versus total with auto transplant. There's actually a randomized trial that was carried out in Germany, looking at 40 patients, where they found a higher reoperative rate in the subtotal group. The total and auto transplant group had more symptomatic improvement, and the subtotal group had a higher rate of recurrence. Recurrences would be easier to manage in the total group because, of course, you don't have to re-enter the central neck. And the authors of this small randomized trial recommended total with auto transplant over subtotal. Again, looking at subtotal versus total with auto transplant, this is a meta-analysis looking at this 18 studies, close to 4,000 patients. And really, the two are very comparable. There was no difference really in the symptomatic improvement, radiological changes, hypocalcemia, persistence rate, time to recurrence, recurrence rate, reoperation rate. The total and auto transplant patients had a longer operative time, had a longer hospital stay, had a lower 1 month calcium level and a higher need for vitamin D analogs at 12 months. But really, the authors concluded that both are effective at controlling secondary disease, and ultimately it was up to the surgeon to choose whichever they felt was most appropriate. What about looking at total parathyroidectomy versus total parathyroidectomy with auto transplant and thymectomy? So again, this is a non-confirmatory multi-center prospective randomized controlled trial, which close to 100 patients where they compared these two groups. And really, there was no difference in the patient characteristics, pre-op data, duration of surgery, hospital stay, and persistence of disease afterward. Not surprisingly, again, the PTH level was higher at follow-up of in the total with auto transplant and thymectomy group, and recurrent disease developed in more patients who underwent auto transplant and thymectomy compared to the total group. So again, the two were felt to be fairly reasonable approaches by the authors, and but they did think that total parathyroidectomy is a feasible alternative therapeutic option to total with auto transplant and thymectomy. So this is interesting. It compared three different treatments, which again another meta-analysis over 5,000 patients, looking at subtotal versus total versus plus auto transplant versus total, and they found that not surprisingly, hypocalcemia, hypoparathyroidism was less common after subtotal or total with auto transplant compared to total. Subtotal and total with auto transplant were fairly equivalent, and recurrence was again most common after the subtotal. Reoperation was higher after subtotal, and so they concluded that they thought that total with auto transplant was the most efficient treatment with the minimal effects. But again, they thought randomized trial was required. What about intraoperative PTH monitoring in the setting of secondary hyperparathyroidism? This is well defined. So it's, as you're, I'm sure, all aware, the short half-life of PTH when we're operating on primary hyperparathyroidism patients allows us to do a focused procedure. And based on the fall in PTH, we predict cure and can do a very focused procedure where we really only dissect and remove a single adenoma. And if we don't, and if the levels don't fall, we can remove more glands and do a wider dissection. Unfortunately, because the impaired metabolic clearance of PTH and fragments, there's a very slow decay in the half-life of PTH in the hemodialysis population, and so it makes the results difficult to interpret. I mean, the fragments of PTH accumulate and cross-react with the assays even, and can give falsely elevated results. There's a lot of papers that have tried to apply a variety of different criteria in different settings for this population, but really it's not something that we use here, and I think that it has sort of limited application elsewhere currently. So the recommendation is that they talk about subtotal parathyroidectomy being the preferred option in the secondary hyperparathyroidism patients, and Ultimately, though, the type of operation should be decided on and weighed by the surgeon and the patient's circumstances. So that not surprising. What about the approach for surgery for tertiary hyperparathyroidism? It's interesting how after a renal transplant, it changes our approach a bit with regards to the management of the parathyroid glands. Again, similar goals. We want to decrease the source of excess PTH, counterbalancing the risk of recurrent or persistent disease versus the risk of postoperative hypoparathyroidism. And we have another option here. We have the three operations we already talked about, but we have another one, which is and again, in this setting, there's no single uniformly recommended procedure. And the final approach ultimately is left up to the surgeon. But for tertiary, there is some literature looking at what we call limited or selective resection, where really the four glands are explored and only, and if there is one or two abnormal glands, those are removed. So if not all glands are abnormal, this is because they talk about up to between 2 to 30% of the time there's single or just double adenomas and in these patients, and with removal of only one or two glands, of the other two or three are normal, and if 3 to 4 glands are enlarged, they recommend you can go to a subtotal parathyroid, and if less than 4 glands are identified, you should consider only a limited resection if the other glands are normal. And so the problem with this is that there is a known higher failure and reoperative rate and with this approach. Our approach generally has been a subtotal parathyroidectomy in the renal population, and in general, I've not seen really normal appearing parathyroid glands in these patients. So for tertiary disease, subtotal parathyroidectomy is an option. Total parathyroidectomy with autotransplant. With no autotransplant, you're guaranteed hypoparathyroidism in this patient population. And so, and then thymectomy is controversial, actually. It could be considered in selective circumstances, but there's really not really much literature at all looking at its practice in the tertiary population. Intraoperative PTH monitoring, this is something that we would utilize in this population because of restoration of kidney function. Again, now we have more of a predictable decline in the PTH, and we use the Miami criteria for defining cure, where we look for the drop of PTH into the normal range and less than half the maximum value at 10 minutes post-resection. Not necessarily have to be a normal range, but we look for a 50% fall from either the baseline or just a level just before the gland is excised. And they give a variety of criteria in the literature, and it can help sometimes in defining that you've cured the patient during surgery with a subtotal and you're not missing some type of ectopic or supernumerary gland, and helps reduce the rate of recurrence or persistence. So we're not doing a focused procedure with these, but rather it's being used to sort of augment the information about the change in PTH that's occurring in that patient. Final recommendation in the guidelines looking at in tertiary patients, the choice of operation should really be left up to the individual surgeon, looking at risks and benefits and decision making. And so we have these approaches. Again, this literature is limited in terms of variability and definitions in different studies, small study sizes, variability in the surgeon and technique, and a lot of different biases that are incorporated. What about parathyroid cryopreservation? St. Paul's is the only place in BC that offers this service. It allows for delayed autotransplantation in patients. It's not as really well defined for secondary or tertiary patients. And most literature that is focused on primary hyperparathyroidism with cryopreservation. The idea behind it is that you can use this tissue as a backup. It's kept in the BC tissue bank for a year for our patients if required, and it can be autotransplanted into any muscle. It would be, again, the brachioradialis would be a common place, though. And it's a backup if you have remnant failure during a subtotal, or a failure of autotransplant during a total with autotransplant, or if some future treatment is required. These cryopreserved tissue has a limited shelf life. They can also progress if implanted and lead to recurrence because they're not normal tissue. And not all of them are fully functional either. So, but they do offer some kind of backup. It would be very unusual for us to do a delayed auto transplantation of cryopreserved tissue on our patients, but it's available. Just to sort of looking at the adjuvants and technique treatments, I mean, we have a lot of bells and whistles that even a few years ago weren't available. We intraoperative ultrasound, frozen section, parathyroid aspiration, radio guidance, fluorescence imaging. Parathyroid is autofluorescence in the near infrared wavelength. It's a tool that can be used to help with their characterization. Recurrent nerve monitoring has been the standard in my practice, and it's shown to reduce risk of nerve dysfunction postoperatively. And vessel sealing devices also have help improve the time, and I believe reduce bleeding from these procedures. But and then there are a number of remote access approaches with ablational technologies that have been sort of started being applied toward parathyroid glands, but I think the jury is still out on these. And then just finally, what about the surgical outcomes from secondary and tertiary hyperparathyroidism treatment? So these are historical numbers, like there's numbers quoted between 4 and 15% of complications with readmission rates up to 17% and mortality up to 3%. I'll give a more contemporary example shortly. Hypocalcemia transiently and permanently are not that uncommon. Again, patients need to be counseled about that in the setting of both secondary and tertiary. This is not primary hyperparathyroidism surgery. The other issue that often is a problem with these patients postoperatively is hungry bone syndrome, where they can be very, very problematic with management of their calcium level, which contributes to not only the reduction in parathyroid tissue volume, but also the hungry bone syndrome. And so they require often aggressive electrolyte supplementation, close monitoring, and treatment protocols. And we have these at St. Paul's when we're monitoring these patients postoperatively. And recurrent nerve injury, perhaps one of the most dreaded complications from central neck surgery, is reported in a small proportion of these patients. I think nerve monitoring in contemporary times has really reduced the risk of this, and there's literature that supports that. So this is really a more contemporary cohort, though still like 10 years old, where they looked at the National Surgical Quality Improvement data, which is abstracted data from hundreds of hospitals across the US, North America, but also other parts of the world. And, about a quarter of patients had morbidity and mortality, but the mortality was very low, less than 1% for both secondary and tertiary patients. And hospital readmission rate was also low. I think with aggressive protocols, you really can help avoid hospital readmission in most of these patients. And not surprisingly, in terms of morbidities, it's the secondary patients had the most morbidity versus the tertiary, and then they compared them even to primary, which was the lowest. Secondary hyperparathyroidism, persistence or recurrence. So persistence implies the presence of unresected parathyroid glands. And the definition of persistence is actually a little bit gray zone, and there's a number of suggested definitions you can see here relative to the upper limit of normal or specific thresholds or numbers of measurements and intervals of time. We talk about 6 months often as an interval to look at what the numbers are like. In terms of recurrence, the growth of remnant glands or parathyroid cells that remain in the neck. And we talk about a rise in PTH at about 6 months post-op. And again, there's a variety of definitions. And this makes this literature very challenging to interpret because everyone seems to have a different definition. And then just finally, the importance of surgeon volume influences outcome. And there's a huge literature now which shows there is not surprisingly, a volume outcome relationship for thyroid surgery, for parathyroid surgery, even for primary hyperparathyroidism. And so not surprisingly, and my group, we did a systematic review where we looked at outcomes in these populations, and it's perhaps one of the key factors in terms of the patient outcomes. And so just in conclusion, secondary tertiary hyperparathyroidism patients are complex. Their care is obviously multidisciplinary. Medical management, decision regarding surgery is really left up to the nephrologist, and it's guided by a number of patient, nephrologist, and system factors. And whereas the choice of surgery is ultimately left up to the surgeon, and influenced by patient, surgeon, system factors. And you can see there are a lot of different options and things that can be done at surgery with it being tailored to the patient and their circumstance. Certainly, I think further studies needed in this area. I would love if anyone's interested in doing a randomized trial in secondary patients looking at surgery versus medical treatment. I'm not sure if anyone would be interested in doing that, but I think there's a lot of exciting opportunity here. Great. Thank you very much. And I'd be very uh, glad for your attention there. And hopefully that was interesting. And I'd welcome any questions.
Thank you very much, Sam. There are a few questions in the chat, and I'll ask people to also raise their hands or add some more. One of the questions was whether or not you use things like alkaline phosphatase in addition to PTH levels to guide decisions.
Sure. So in terms of alkaline phosphatase levels, we measure them. I don't think it necessarily uh, uh, guides decisions and guides our decision making. I think it does help us predict which patients are going to be significantly more difficult to manage post-op. And I can think of a few people who, and I'm sure many of you can think of some patients where when the alkaline phosphatase is quite high preoperatively, they can have just very resistant hypocalcemia, and they can require prolonged hospitalization and more aggressive calcium replacement and electrolyte replacement post-op. But it doesn't necessarily have a huge impact on surgical decision making. I think my impression is that we'll do the other interesting offshoot of that is like the bone hunger and even like the bone
Yeah,
health in this patient population. And it's I'm so used to seeing bone density tests on all my primary patients, and then I'm like at one point
yeah,
I'd ordered bone density testing in some renal patients, and then like I got really a lot of dirty looks from nephrologists, and then I was like, okay, well they're all going to be abnormal. They're
yeah,
not,
exactly.
so that's a whole kettle of fish. But yeah, no, I think that the bone health in this patient population is certainly it's challenging, but yeah, alkaline phosphatase. I think it's a good flag for us to help predict post-op management to post-op challenges with these people.
Yeah.
Um,
And I guess I have a question. So you talked about numbers of surgeries done. So do you have an estimate of the number of surgeries done either A and BC or at B at St. Paul's or C in Vancouver Coastal? Because that would give us a good understanding of perhaps how and if we were to consider an RCT in the province, whether or not how we would do that.
right. Yeah, no, I think that's a great question, and I think it's a real challenging question, and I don't personally have a great sense in terms of how many patients provincially are undergoing parathyroid surgery. And I think it's a fantastic research issue with the renal data sets that you had. I mean, I'd be very interested to know what the PTH profiles are like on these people relative to the numbers, and if and what. But so I don't really have a sense in terms of how many. I see people from all over the province for this surgery, uh, and in general, usually it's people often who have quite extreme disease with PTH levels, like sometimes even off the scale.
Yeah,
I think there's a variety of contributing factors, and it's often a sort of a very challenging patient population. I mean, I think there's even a significant subset of these patients where there are a lot of compliance issues as well, sometimes with regards to their treatment. I mean, I think you'd have a better perspective on that. But my general sense is that there's potential to be more systematic in terms of the criteria that are applied and triggering. Not that I'm looking for a million subtotal parathyroidectomies, but I think that we may not be as aggressive in BC with having these patients go for surgery as opposed to some other provinces. But I'd be interested if you have access to that kind of data through your data set.
no, it's interesting. I mean, I think I'd ask, all of us as clinicians is like, we don't have it. I'm not sure that we do have a systematic approach, number one. Number two, I think the limited access, not just geographically, to skilled parathyroid surgeons is going to change people's behavior, right? And then, transplant candidate, not transplant candidate also impact. And so I think it's complicated in this province, but it would be interested, if there is an appetite for people who are interested in the area to sort of say, could there be a consensus amongst the nephrology community as to who they would refer? Because right now, I don't think we even have there's not standardized referral criteria in the province to you, so you wouldn't even know what the denominator is, let alone, right? So I think that
Yeah.
that'd be a first start.
I I think it would be interesting to see what the PTH levels are like in the provincial patients, and I guess I suspect you
So
have.
we have that data. I mean, I don't know that anyone's looked at it recently in terms of the number of people with levels over 65, right? Just for easy, like just from the KDIGO guidelines. I don't know if other people have a better sense in the audience and wanted to weigh in. Um, with the advent of cinecalcet, I think that's also changed perhaps the incidence of severe hyperparathyroidism, but that would be the hope. Does anybody on the line have any thoughts or questions as additional? Just scrolling to see who I can call out on this, but
I was just going to say that is that for the tertiary patients at St. Paul's, we do have we developed a sort of a protocol for them, and I think they're a little bit more of a straightforward population than the secondaries, where based on elevated calcium and PTH within a period of time, it does trigger sort of referral. So we have developed a bit of a pathway for that population, and so. And I think it sounds like I think it's helping quite a bit. Yeah.
So to your knowledge, like in the province, yourself and Adrian and who else are doing the parathyroidectomies?
And provincially, it's a great question. I mean, I think that the ENT surgeons at the general do some of this work, but it's not really. I mean, I see people from different parts of the province, and so it's not something that's really embraced in many places, and as well that the lack. I mean, not that we really need to access the tissue often, the lack of cryopreservation and intraoperative PTH is available in some places, though it's not the same as what we have with because we do such a high volume of primary disease at St. Paul, because we're really the provincial center for that. So I think it's really hit or miss, to be honest with you. I mean, I don't think there is like I'd be very interested to know, because I've had tried to get sort of MSP billing data and that kind of thing, just to see, like, to get some sense in terms of what's going on provincially. And I think really probably the only people who know are the nephrologists.
Yeah, maybe that's
So
what
somebody up north, or somebody in the interior, etc. Like, are there patients undergoing undergoing parathyroid surgery? Are there secondary patients, or are there, and even some of the tertiaries, I guess. Yeah.
Yeah, I think, again, I think it's interesting how little we know about what's going on here. And, but I think that, this presentation maybe will spark some interest in perhaps standardizing or understanding better what it is that is going on, and what are the levels, and who is being referred to whom. And, maybe it would be something that people want to work on in terms of a systematic approach, right? Because I think it is dependent on lots of different moving parts, as you said, right?
Definitely.
Including, yeah. Anyways, that's at the bottom of the hour. Thank you very much for all the work that you put into that, and for certainly a surgical perspective, which we don't often hear or think about, and not appreciating the totality of literature on this topic. So thank you very much for that excellent review, and stay tuned in case there's some people that want to do a deeper dive into the data around this. Thanks very much, everyone, for your attention, and Sam for presentation. Thank you.
Thanks, everybody. Have a great day.